Eating disorders are mental disorders that are defined by a certain set of criteria. An individual who develops one has a set of psychological beliefs or coping strategies alongside a preoccupation with food and weight. So they show lots of behaviours around how they deal with food and what they like their weight to be and how they try to control their weight. And in women, we also expect them to have abnormalities of periods or menstrual cycle. So it's important to have those three criteria to actually be able to diagnose an eating disorder. For somebody to be able to develop an eating disorder, they have to have an underlying biological predisposition. So although lots of factors are important in when they develop, and for that individual why they develop, unless you have the biology, you can't develop an eating disorder. And those abnormalities in biology are revealed because of the starvation. And now from the research we understand that they are to do with cerebral blood flow and also to do with serotonin, the happy chemical, in very specific parts of the brain. Lots of people think they develop because of pure psychological reasons, but we now understand that you could have two girls on exactly the same diet with the same psychological makeup, and one will develop the eating disorder because of the starvation, but the other one doesn't. It's very important to put into context the underlying vulnerability to an eating disorder and understand then, after that, what the triggers are for the individual. And indeed, they might be psychological upsets, stresses, difficulties in relationships, or life changes. But the actual fundamental reason for people to develop an eating disorder is because they starve, and that produces changes in the brain. Eating disorders differ from just being a fussy eater. Somebody who's a fussy eater may be what we call a selective eater. They may just not like certain flavours of foods or certain types of food, or be very particular about their food. But unlike an eating disorder, they don't have a preoccupation with weight, shape and food control to that extent. Their self-esteem is also not based on that control. So a fussy eater is just a fussy eater, whereas somebody with an eating disorder has a psychological difficulty and their self-esteem is very much centred around the control of food, weight and shape. The person with anorexia will always present as being underweight. That might be slightly underweight with a BMI of 17.5, or they may be drastically underweight. The difference between that and bulimia is that people with bulimia are normal weight, and people with binge eating disorder are again normal weight, or perhaps sometimes overweight. So the individual with anorexia has a lot more physical manifestations because of the starvation. So they'll present as tired, as cold, as depressed, as more obsessed, have difficulty completing normal everyday tasks, difficulty moving. They'll have a low blood pressure, an abnormal ECG, a low pulse rate and a low temperature. And very importantly, they may be wrapped up and covered up so you can't see any of those changes unless you specifically screen for them or look for them. The individual with bulimia may actually present as appearing to be okay, and you may pick up small signs such as enlarged parotid glands around their submandibular or parotid area, or you may actually see scoring on the back of the hands because they have deliberately induced purging and caught their knuckles on the edge of their teeth, and those are important physical signs to look for. In most women with eating disorders, bulimia, binge eating or anorexia, they develop irregular periods or amenorrhea, and so that's a very important symptom to ask for. Most people with eating disorders present with psychological difficulties, and the majority of those are around anxiety and depression. Frequently, the person who is presenting for the first time to the GP, once they start to reveal the symptoms, will probably be very tearful, but they may come talking about depression, anxiety, difficulty coping, feelings of stress, and most importantly, and almost always, a difficulty sleeping and concentrating. But probably the most common presenting complaint is a low mood and feeling stressed, unable to cope. It's important to ask the questions of a patient in front of you quite directly, because unless you ask them, it's unlikely that you'll be given the answer. So it's important to say, are you worried about your weight? Do you find that you have been losing weight or gaining weight or feel out of control with your eating and weight control at the moment? And then perhaps to spread out, do you find that food dominates your life? Does it stop you in social situations? Does your body image concern you to such an extent that it would prevent you doing normal activities? And then also to ask about other symptoms such as anxiety, depression, sleep, and most particularly in women to ask about their periods. And then to move on in an interview to ask about their various interests in life. Have those been curtailed lately? Are relationships and friendships more difficult? Have you felt yourself withdrawing from your day-to-day life and not enjoying things in the way that you would have done? And do you feel that the thoughts of food and weight dominate your life? Once you've confirmed the diagnosis of an eating disorder, or you suspect there is an eating disorder, it would be very important to attempt to refer the patient on to a specialist service. Some patients will resist this, and so you need to work in a motivational way to perhaps make suggestions to them to find out more about their difficulties, directing them towards perhaps the Priory website to look at what treatment offers, or also thinking about the BEAT website. BEAT is the leading UK charity in eating disorders, and they have a lot of descriptions about eating disorders. Or indeed you may want to offer the self-help book, Overcoming Binge Eating by Professor Christopher Fairburn. All of these things give the patient a lot more sense of control and that treatment is within their control and they're not being directed against their will. A very important feature with a patient with an eating disorder who desperately wants to retain control. The vast majority of patients can be treated for their eating disorder as an outpatient, and sometimes they need daycare or inpatients, but the vast majority should be treatable as an outpatient. And it's important to get quite specific, specialised treatments in eating disorders, and that would include both a cognitive approach, cognitive therapy specific to bulimia, or what we call interpersonal psychotherapy for anorexia and bulimia and binge eating. Always expect a specialist treatment to have some dietetic input. And again, at the Priory we would offer a one-to-one therapist, and then we would offer dietetic help as well as medical assessment and ongoing monitoring. It's important to have those components of care so the patient has a full assessment, both physical and psychological, and ends up with a specialist psychological treatment. Prognosis in the outcome of eating disorders is dependent upon the duration of illness, how rapidly somebody's referred into services, and if they're referred into specialist services. So we would hope, once a diagnosis has been made, that the GP refers into somewhere like Priory services who offer a specialist eating disorder service as soon as possible. The younger the patient is, the better the outcome, and the more specialist the service, again, the better outcome. Inpatient units are very variable, and we know at the Priory if we are able probably to bring about a 50 to 60 and sometimes 70% success rate, depending on length of stay, depending on the duration of illness that's been present and the age of the patient. The faster people get into treatment, the younger they are, and the shorter duration of illness, the greater success we will have.